view on Indigenous people's health. And so, as you might have read in the description, Dr. O'Sullivan is going to be our first speaker, and he's going to shed a light on some pretty significant differences in life expectancy between Indigenous and non-Indigenous people. And they're present in Canada, and they're somewhat lessened in New Zealand and Australia. And Dr. O'Sullivan is going to come to talk to us a little bit about how and why they're different and what we could do in Canada to better those differences. So Dr. O'Sullivan is a Maori scholar at New Zealand. He's a professor of political sciences at Charles Sturt University in Australia. And he's also an adjunct professor in the Central for Maori Health research at the Auckland University of Technology. He's a publisher of 8 books, and he's coming to speak to us today from Australia. So it's 4 a.m. this morning. So we're this morning for Dr. O'Sullivan. So we're very grateful for him to come and speak to us today. So you can go ahead.
Kia ora hui tātou katoa. Ko te mea tuatahi, ka mihi ki te rongarawa, I o matua kore. He honore he karoria ki tāne ingoa, he maungarongo ki te whenua, he whakaaro pai ki ngā tangata katoa. Ko mamari te waka, ko te rārawa te iwi, ko te uri o hina te hapu, ko te uri o hina te marae. Ko Dominica Sullivan tōku ingoa. Bonjour à toutes et à tous. Merci beaucoup pour l'invitation à vous parler aujourd'hui. Je vis à Canberra, en Australie. J'ai dit en Maori, je suis de Nouvelle-Zélande, des peuples Te Rarawa et Ngāti Kahu. Mes ancêtres ont signé un traité avec la Grande-Bretagne au XIXe siècle. Ce traité a accordé à l'État britannique le droit d'établir un gouvernement pour les colons britanniques. En retour, la Grande-Bretagne s'engage à protéger les intérêts des Maoris vis-à-vis de leurs terres et leurs ressources et de leur accorder les droits sujets britanniques. De nos jours, on peut comprendre ces droits en tant que droit de citoyenneté, le droit de participer à la prise de décisions et d'influencer les politiques publiques, notamment les politiques de santé. Cette aspiration à avoir du poids sur les décisions publiques aussi très important pour les peuples autochtones en Australie. Closing the Indigenous life expectancy differential by closing the gap in political power. The basic proposition here is that life expectancy differentials don't just occur by themselves. They don't just occur because of poor clinical practice or because of poor diet, poor nutrition, etc. They occur because there is a gap in political power. And I would suggest that the size of the differential in life expectancy is a proxy for the extent of the differential in political power. And I think there are various ways in which those gaps may be closed to allow people effectively to have greater opportunities to influence public policy, to influence the ways that health systems work. Health systems like education systems, criminal justice, all those arms of the state, they're designed by people who hold power, and they are designed to help those people maintain power. They're not designed necessarily to serve the people who don't design them as effectively as they are designed to serve those who do design them. And I think that's an interesting and important point. So while there is a big life expectancy differential in Canada between First Nations and other peoples, that differential is not unique. Canada is not out there on its own in terms of not being terribly successful at these things. But things are worse in Canada than they are in Australia and New Zealand. Now, that's not necessarily to say that we should hold up New Zealand and certainly not Australia as models for Canada to kind of copy, because we get a lot of things wrong in this part of the world, but there are maybe some political principles and values that we're starting to think about a bit more in this part of the world that I think might be helpful in terms of closing this differential in life expectancy, because they might be successful in closing the differential in power. So the life expectancy differential between Māori and other New Zealanders is about 7 years in New Zealand. And it's been around that mark for quite some time. And in spite of a lot of money being directed towards Māori health, it hasn't necessarily been done in the most effective of ways. And I'll talk a little bit about what some perhaps more effective ways are that have been contemplated at the present time. Similarly, in Australia, we have an 8 to 9 year life expectancy differential. And it's really only been in the last few years that the Indigenous demand for a greater say in health policy and in the delivery of primary health services has started to be accepted slowly and almost begrudgingly by governments. But there are signs that when Indigenous communities are in control of their primary health services, people are more likely to make use of them. People are more likely to find that they operate in ways that are culturally legitimate and culturally understandable and acceptable to people, and therefore they're quite significantly more effective than those services that are set up to serve everybody without that distinctive cultural focus. So these differentials compare with a differential of around 10 years in Canada. And I would suggest that in Canada, the power gap is the biggest of these three jurisdictions, and in New Zealand, it's the smallest, but still a differential nevertheless. There are also regional and other socioeconomic variations. So when we look at national figures, we've got to keep in mind that they summarise a much more complicated and much deeper story. For example, in some parts of remote and regional Australia, the life expectancies are significantly lower than they are for Indigenous peoples in the cities, for example, where access to healthcare, access to nutritious diets and so on are more freely available, as it is in Canada, out in remote areas. The costs of accessing nutritious foods, for example, are prohibitive for many people. And out in regional areas in Australia, for example, we still have a fairly high incidence of trachoma, a disease which is eliminated from the first world almost completely. But, because of often contaminated water supplies, for example, basic hygiene is not as easy to manage for people as it is if we're in town, where you just turn on the tap and some clean water comes out and you wash your face. So these kinds of differentials and obstacles to good health don't necessarily exist in the same ways across the whole country. And in New Zealand, for example, we're seeing the COVID-19 vaccination rates much lower among Māori populations than amongst others. And in New Zealand, the vaccine rollout is managed by district health boards. I think there are about 21 boards that look after different geographic areas across the country. And the one that's doing worst for its Māori population has a chief executive who won't even expose herself to media scrutiny, won't agree to media interviews, won't allow, won't, I guess, give an account of what's going wrong, or won't attempt even to defend what's going right. And that's a gap in political power. I think if it were a Māori chief executive, the expectations from family and from the community of which he or she was a part would demand a level of accountability and explanation when things don't go right. And I think also perhaps a Māori chief executive would have perhaps a more vested interest in doing the right thing by his or her people. So that's a good little example, I suppose, of why I make the argument that Indigenous participation at every level of the policy process, whether it's as a member of the cabinet, a member of parliament, chief executive of a health board, or a clinician on the hospital floor, participation at all of those levels is really, I think, a critical part of closing this power gap, which might then lead to better health outcomes and a closing of the life expectancy differential. In Australia, the life expectancy differential is principally explained by the number of Indigenous people who die prematurely, but from causes that are preventable. So we're not talking here about a genetic disposition to die young. We're talking about things like heart disease, suicide rates, and complications arising from diabetes, all of which are preventable. Less likely to happen when one has access to nutritious diets, for example, which not everybody has because of the way supply chains work, because of discrimination in the labour market, making access to well-paid jobs less likely for many people. All those sorts of things which are what we might call political determinants of health. I know there's a huge scholarship dealing with what they call the social determinants of health. And while I think it makes a useful contribution to policy thinking, those things, like overcrowded housing, for example, which we all know contributes to the spread of certain diseases, is a social determinant of health. But overcrowded housing, for example, doesn't come from nowhere. It comes from the political decisions that policymakers and governments have or have not made over time. So it's poor housing, as an example, is very much a political determinant of health. Whether or not Indigenous peoples get a fair go at school is not just a matter of luck, but it's a matter of the political decisions and the political values of decision makers throughout the education bureaucracy, whether it's the Minister of Education, whether it's the teacher on the classroom floor, choosing to maybe teach Indigenous people not as effectively as he or she chooses to teach other people. All those sorts of things are political determinants of health. They're not purely social, and they don't occur by themselves or by chance. So it's for these reasons that I suggest here this morning or this afternoon in Montreal that the gap in life expectancy is a proxy measure for a gap in political power. And what this means, I think, is that solutions to Indigenous health are concerns of moral and political philosophy as much as they are the concerns of clinical practice. So when you go to work in your hospital, you're taking a set of clinical skills with you, but how you choose to apply those, whether you choose to apply them equally well, whether you choose to apply them with recognition of the cultural context of one patient but not of another, those are moral and political decisions. And they are going to be as significant as your clinical skills, I suggest, as determinants of whether or not you get a good outcome for your patient. And the philosopher Norman Daniels, who's, I think, well worth reading if you're interested in the the moral philosophy of health, not just in relation to Indigenous peoples, but in relation to whatever kind of care you might be providing for whatever patient. I think Norman Daniels' work is really interesting in terms of the explanations that he gives for health policy's moral importance. And he says that health is morally important because specifically by keeping people close to normal functioning, healthcare preserves for people the ability to participate in the political, social, and economic life of their society. It sustains them as fully participating citizens, normal collaborators and competitors in all spheres of life. So while we might say, education, for example, is a determinant of good health, we might also say that good health is a determinant of good education, because people who are healthy obviously are better able to take advantage of the opportunities that the education system provides, not just as a kid going to school or a student going to university, but as they get on in life as fully participating citizens, having their voice in public discourse and making their contributions to what schools, for example, are actually there for and what they do. They all presuppose a level of health, participating as an active citizen in public discourse, contributing to the formation of social values and cultural values and all those sorts of things, much easier for the healthy person to do. So that gives health a moral and political importance, beyond the significance of just, being able to fix somebody's broken arm or whatever it might be. In 2016, the Australian Medical Association, which is the professional association of doctors, and it's quite a significant participant in health policy in Australia. It's played a very significant role in debates over the management of the COVID-19 pandemic and vaccine distributions and so on. It takes a very active interest in refugee policy and the impacts on people's health and well-being that the Australia's offshore detention policy has. It's a very significant policy actor and lobbyist, obviously, serving the self-interests of its members, of its doctors, but also taking a broader interest in public health debates. And it publishes what it calls an Indigenous Health Report Card every year. And I guess if you're interested in just a brief overview of what's going on in Indigenous health policy at any one time, these annual report cards, which one can download from the Medical Association's website, are a really illuminating read. An easy read generally, but quite illuminating and instructive. Anyway, in 2016, its annual report card dealt with the topic of the incidence of rheumatic heart disease among Indigenous peoples, and it explained some of the clinical measures that are being taken to try to treat this condition more effectively and so on. But its conclusion was that it's not primarily a clinical solution to the Indigenous burden of rheumatic heart disease that is required, but that the solution is simply political will. So what they're saying here is if we want to address rheumatic heart disease, we can do it. And the fact that it still exists in disproportionate, afflicting Indigenous peoples in disproportionate number, is the fact that the political systems to allow, I guess, clinicians, especially Indigenous clinicians, to actually take the lead, for Indigenous communities to take the lead in terms of developing programs that work, culturally contextualized programs that work, and then being able to replicate them when they're successful. Those sorts of things are actually more than just the skill of a doctor. They're the political values of political decision makers that are at play here as well. Political institutions are not always designed to give each person equal opportunity to participate and engage with other citizens as peers, as Norman Daniels suggests that they should. So the question I think that it's useful to think about is who makes decisions for whom and why. And that might lead us to deeper insight into why Indigenous rates of diabetes, for example, are significantly higher than for other people. Who makes the decisions about where and when clinics will operate? Who makes the decisions about who works in them? Who makes the decisions about the cultural values that will inform their work? Who decides who to talk to in a particular Indigenous community about what's needed and why? Are those decisions made to empower people, to improve people's health, or are they made to perpetuate a colonial political order? Or is there some kind of confusion about how those two objectives might interact with one another on the ground? And does that confusion perhaps have too much influence over decisions? Are there barriers to people making choices that are consistent with good health? Access to medicines, access to nutritious diets. One of the reasons, for example, that in Australia and also in New Zealand among the Māori population for the COVID-19 vaccination rates being a bit slower than the rest of the population is that Indigenous peoples in both countries were among the last to get access to the vaccine. And they're now among those who are most disproportionately becoming infected. And in both countries, there were political decisions to prioritise other people. Sometimes those priorities made sense, frontline health workers, people working on the international borders at international airports and so on. Those people, obviously, there were very good reasons for prioritising. But you see, one of the other main criteria that were used in both places, as they were around the world, was to vaccinate older people first, following the argument that older people were more vulnerable. But there was also evidence that Indigenous peoples, for all sorts of reasons, also had greater vulnerabilities. But as their age structure in both countries is significantly younger than that of the wider population, Indigenous peoples were sort of at the end of the queue simply because they were disproportionately young. And now what we've got in New Zealand especially, a hugely disproportionate number of Māori people being infected, as we speak. And that was avoidable. Arguments were put to government. Māori members of the cabinet put the argument that this was likely to be the outcome, and put the argument for some level of priority for younger Māori people. I guess because the government decided that would be a hard political sell, it would be presented by or attacked by opposition parties as a race-based preference. The government decided it didn't want to take that political risk. But if it had taken that political risk, the overall rate of COVID infection and all, which is rising quite rapidly, would probably be more likely to be under control at the moment. So it's a good example of how a clash of political values means that one is also making a choice about the outcomes. Will one population be disproportionately more badly affected than another? And that's what's happened here. And also, there are further political questions like how well do education systems prepare people for access to the labour market and access to wealth as a determinant of good health. There's a very large and comprehensive scholarship showing that wealth is a determinant of good health. Indigenous peoples tend to be poorer, and that's ultimately, I think, the root of that is land alienation, land confiscations that took away from people the capacity to not only use their lands for spiritual sustenance and so on, but also for material sustenance, to grow food, to derive an income from the productive use of land, is sort of been taken away from people in many respects, and not necessarily replaced. Schooling doesn't work as well for all sorts of reasons, but one of the big reasons is racism. A lot of research has been done showing how racism actually influences the classroom practices of individual teachers, so that the teacher might say to you, well, I care for everybody in the same way, but everybody's needs are not the same. The cultural values and expectations of what schooling is for that different people bring into the classroom are different, and effective teaching presupposes awareness of those differences and attending to what they mean in terms of the pedagogies that one uses. And when that doesn't happen, you get different outcomes, and therefore you get different access to the better remunerated ends of the labour market, and also high-paying jobs tend to be physically less demanding, tend to be a bit more pleasant often than some of the unskilled work that people may be are more likely to go into if they're an Indigenous person who's had a not very good schooling, for example. But the picture is not entirely bleak, because while these problems that I've identified are serious and really do have a significant negative impact on people's opportunities for good health, political systems, and liberal political systems like we have in Australia, New Zealand and Canada, don't necessarily have to work in these exclusive ways. And I think, it's useful, therefore, to think about what kinds of political arrangements might give people fair access to decision-making authority. Because justice is not simply about the fair distribution of resources, but the fair distribution of political authority. What should it mean practically for an Indigenous person to be a citizen? What are the rights of citizenship? What are citizens empowered to do in terms of influencing the ways in which their societies work? So not just what does it mean to be a citizen in a general sense, but what does it mean to be an Indigenous citizen specifically in Australia, New Zealand or Canada? One example from New Zealand is the Māori seats in Parliament. Since 1867, Māori have been guaranteed a certain number of seats in Parliament. At the moment, it's 7 out of 120, and Māori people are still elected to other seats that are available to the general population as well. But these seats give Māori voters a distinctive voice. It means that there are people in the Parliament who are elected to, I guess, scrutinise public policy from a distinctively Māori cultural lens. They're able to, as candidates for election to Parliament, they can make their cases for election to their voters in distinctively Māori ways. And voters can judge the candidates available to them from a distinctly cultural perspective. And those cultural perspectives are not therefore at risk of being drowned out or marginalised by the needs of majority population voters. So that's one of the ways in which things work in New Zealand. And recently, New Zealand changed its electoral system. It did have a first past the post system, more or less identical to Canada's. But it adopted about 20 years ago the German mixed member proportional model, which means that about half the parliament is elected from party lists, and the practice has been to place a reasonable number of Māori high up on the party lists, so that we now have a situation in New Zealand where about 15% of the parliament is Māori, which roughly matches the Māori share of the population. And for the first time ever, a quarter of the cabinet is Māori. And there's an Associate Minister of Health who holds one of the Māori seats in Parliament and has specific responsibility in respect of Māori health. So when we're, say, looking at the disproportionate impact that the COVID-19 pandemic is having on Māori, one of the things that is different from what we would be dealing with if this had happened 20 years ago is that there is a Māori minister in the cabinet with a specific mandate to argue for a better deal, basically, for Māori people. There's nothing equivalent to that in Australia. There's one Indigenous member of the federal cabinet, and he doesn't have a great deal of influence. He's a member of a party that has traditionally not been very sympathetic to Indigenous claims, and whatever voice he tries to exert doesn't have a particularly attentive audience. So what Indigenous people in Australia have agreed upon, with obviously some dissenting voices, but there's a strong view that the Australian Constitution ought to be amended to create what it's calling an Indigenous voice to Parliament. And this would be a body of, I know the numbers haven't been agreed upon, but maybe 12, 20 people who would be elected by Indigenous people from around the country. And they would have, it wouldn't be a chamber of the Parliament, it wouldn't be something akin to a Senate or an upper house, but it wouldn't have the power to legislate, but it would have the power to scrutinise legislation before Parliament. It would have the power to propose amendments to existing laws. It would have the power to question ministers and bureaucrats and ensure that an instinctive Indigenous voice was enshrined in the Constitution as an integral and permanent part of the political structure of the state. So that voice would always be there. It wouldn't have a decision-making power, but it would certainly have powers of influence, powers to ask questions that Indigenous people thought needed to be asked, powers to raise proposals, powers to really influence how the vaccine is being distributed, for example, and to offer public explanations as to why it's not working very well and to what could be done about it. Now, I mentioned a moment ago that a couple of the district health boards in New Zealand are doing a very, very poor job of vaccinating Māori populations. Now, at the present time, there are a lot of Māori primary health services, for example. They get their funding through contracts with the district health board. And that contracting process is quite complex and complicated, and sometimes many people argue quite discriminatory. So what the government has agreed to do in response to Māori arguments in favour of this proposal over a number of years is to establish a national Indigenous health authority. So when a Māori provider says, we can vaccinate 10,000 people, for example, give us a contract to do that, it won't be going to a district health board run perhaps largely by non-Māori people. It'll be going to the Māori Health Authority, which will be made up of senior Māori clinicians, academics, policymakers, and so on. So people who, from a very well-informed perspective, can say when this primary health provider comes along and says, give us a contract for 10,000 vaccines, it can, from a very informed perspective, say, well, how are you going to do it? How is your proposal going to work? How do we know that these 10,000 people are going to be reached? Some of them have really complex comorbidities and health needs and social needs and stuff like that. How are you going to reach these people? And the questions will be asked by Māori experts. So the health provider will have to give answers that make sense culturally to these senior clinicians and academics and so on. So how are you going to reach these people that maybe the mainstream health system isn't very good at reaching? How are you going to do the job differently? They're going to have a really well-developed, culturally informed answer to that kind of question. And that, of course, model will apply not just to the distribution of vaccines, but to all aspects of primary health care, GP services, nursing services, perhaps pharmacology, and so on. So this is a really significant development. The legislation to establish the national authority has been passed by Parliament. It's not yet operating, but the first members of the authority have been appointed, and things like its budget, its contracting processes, and all those technical sorts of things are being worked out. And it will be in place and running fairly soon. So instead of going to a non-Māori organisation in terms of a district health board to get funding for primary health needs, people will go to this Māori Health Authority. And I guess they'll have to make their bids in ways that are culturally authentic and sensible, and they'll have to report to the authority in those terms, and the success or otherwise of their work and whether they get further contracts will be evaluated from a Māori cultural lens, I suppose. So for the first time ever, the structures will be in place to allow Māori people to say, this is what we want from the health system. This is what we need it to do right now. Yes, diabetes is a big priority in our community, or no, it's not. We're going to bid for support for other things. Those kinds of decisions will be made by Māori people. And that's what I mean by a distinctive Indigenous citizenship. So participating in basically how government works, not just as any old citizen, but participating in how government works as Māori. And I think, there are small-scale precedents for that going back a long time, but there's no precedent as large as this, not just in health, but probably in any field of public policy. So I think a very interesting model for Canada to watch, I would suggest, and see how it works. Now, the political philosopher Iris Marion Young suggests that participation and meaningful voice is also important. Excuse me. We're at the height of hay fever season in Canberra. Had our highest pollen count in 20 years or something a couple of days ago. So it's not the best time for it. But anyway, participation and meaningful voice is also important, because the only ground for a claim that a policy or decision is just is that it has been arrived at by a public which has truly promoted the free expression of all. So what I've just outlined, hopefully, is a model for free and culturally informed expression, or a political expression which is free simply because it is able to take place from a cultural perspective and so on. And I think my point really can be summarized through the phrase culture counts in public decision-making processes. And I think New Zealand does these things better than Australia or Canada, and this is why the life expectancy differential is not so wide. But 7 years is still a big difference, and the political explanations may still be more powerful than the clinical. And like I said, for the first time, we're about to put that proposition to the test. And I think why the political is so important, I think, was summarised by a former leader of the Māori Party and Associate Minister of Health in 2013. Over the years, she said, the findings have been conclusive. Māori receive fewer referrals and diagnostic tests and less effective treatment plans from their doctors than do non-Māori patients. It goes further. Māori are interviewed for less time and are offered far fewer opportunities for treatment. They are prescribed fewer secondary services such as physiotherapy, chiropractors and rehabilitation. And worst of all, in too many cases, Māori are either blamed for their plight or the professionals treat them in such a way as to presume that they have a natural inclination towards the various illness. There was one tragic case that was widely reported in the media recently of a bloke in his 60s or 70s taken to hospital with a stroke. And without asking, the clinicians treating this bloke assumed that he was a smoker and therefore that his prospects of recovery were slim. So they didn't bother to even consider the full range of possible treatments. And it was only when it was commented in passing by a family member that this guy didn't smoke that the whole nature of the conversation and of the treatment plan changed. And the initial assumption was based on a racial stereotype that Māori men in their 60s who have strokes are smokers. And it might be true that that's often the case, but making a racial assumption that it is the case and not asking the question is just one example of how political or moral values can override clinical skills in terms of their relative influence over the quality of the care that's provided. In 2008, the Aboriginal and Torres Strait Islander Social Justice Commissioner argued that improving Indigenous health in Australia required evidence-based policy development and evaluation against established benchmarks, coordination and cooperation among governments, and Indigenous engagement in the policy process. In 2021, policy progress towards these ideals is starting, but is still not secure. In 2020, the Prime Minister acknowledged that exclusion was one of the things that explained sustained policy failure. And although the government may not have acted on this observation terribly well, I think it's still an incredibly important and insightful one. And this is Scott Morrison, the Prime Minister, saying that despite the best of intentions, investments in new programs and bipartisan goodwill, closing the gap has never really been a partnership with Indigenous people. We perpetuated an ingrained way of thinking, passed down over 2 centuries and more, and it was the belief that we knew better than our Indigenous peoples. We don't. Partnership now informs the new policy paradigm. This means formal partnerships and shared decision-making, building the community-controlled sector. It's community-based health clinics and so on, community-owned but publicly funded primary health clinics, transforming government organisations, shared access to data at a regional level. The philosophical shift from an exclusion to inclusion is significant. In New Zealand, the Treaty of Waitangi's inclusive presumption influence health policy. As I said at the beginning, the treaty gave the British Crown the right to establish government. In return, Britain offered protection of Māori authority over their own affairs and natural resources, and the rights and privileges of British subjects, which today we call citizenship. The treaty means that Māori do not contest the post-settler presence, but they do contest the Crown exercising a unilateral sovereign authority. In 2019, an administrative tribunal, the Waitangi Tribunal, found that despite clear intentions, the state fails to deliver good outcomes for Māori. It found that Māori primary health services were underfunded, and that's why it recommended that primary healthcare funding decisions be made by this independent Māori Health Authority. And just again on that theme, independent Māori decisions brings Māori people and values to the centre of the policy process. It means that Māori people are not the subjects of state policy, they become its agents, exercising meaningful citizenship and the right to take responsibility for their own affairs. The potential is for a Māori primary health system explicitly focused on Māori needs. Māori decision makers would decide what needs to be done, how and by whom. I think the question of who decides and how and why and by whom is really important politically. The success of the authority hinges on how independent it will be and its accountability to Māori people. Okay, and with a couple of colleagues at the Auckland University of Technology and Massey University in New Zealand, I developed a policy evaluation tool called critical tiriti analysis. And that suggests that the authority will be most likely to succeed if it can help to address these questions. How will the health system maintain correct relationships with mana whenua, that's local groups with authority over the land, mātakawai, kinship groups, families, and other Māori communities? How will the health system's processes, actions and decision-making be informed and shaped by Māori worldviews? How will Māori-led decision-making and leadership, which is a bigger aspiration than the partnership that we're talking about in Australia, be put into practice across the sector? How will barriers to Māori advancement, such as institutional racism, be eliminated? Given the history of health inequalities, how will resources be distributed and prioritised to ensure equitable outcomes for Māori? How will Māori worldviews be normalised within the health system? So not some kind of peripheral afterthought, but how will they be central? How will we know that when we're going to a Māori health provider, we're going into an institution that reflects our worldviews, that is genuinely part of our community, and so on? What are the signs that that's happening? J'espère voir attirer votre curiosité sur ces problématiques. Merci pour votre attention. Avez-vous des questions en anglais, s'il vous plaît? Kia ora hu tātou katoa. Kāna te miki. So thank you, everybody, and I hope that raised some more questions for you and pose some things to think about that might be useful in your own context and that might help to make Canada a more equal and fairer and just society and help you to make your own contributions to that. But no, I've talked a little bit longer than I said I would. I'm sorry, but if we've time for some questions, that would be good.
If anyone has a question, you can just unmute your mic and say it, or write it on in the chat, and we'll read it.
So I had a comment about a comparative with Quebec. So we discussed earlier this morning, and it's been really mediatized in the recent months that the Quebec government doesn't recognize that there's systemic racism within Quebec. And so I was wondering what's your point of view on that and how it can really affect how the government manages the health crisis, I'd say, Indigenous health.
Well, I think if the government doesn't recognise systemic racism, that actually in itself tells us that systemic racism is a major problem and entrenched. I guess political advocacy, academic advocacy that shows very concisely some examples of that systemic racism and what it actually means for people. If we can explain First Nations health outcomes as being partly a product of the way the system works, rather than the product of bad luck or the product of individual bad choices, then I think we have at least a morally powerful foundation for some kind of political advocacy. Whether it's politically powerful, I guess, depends on how persuasive it is, how attentive governments are to listening, how willing opposition parties are to prosecute the argument. But I think, as individuals, I guess being alert to where it is present and how it is present and how it works, and doing what is available in one's clinical context or academic context to challenge these things. I publish a lot on this sort of topic, as do many others, and I think collectively that kind of advocacy perhaps has contributed towards the New Zealand government's decision to accept this independent Māori health authority. It's not a new idea. I'm certainly not the only one who's been arguing for it for a number of years. Many people have. But political change does take time. But consistent advocacy and consistent explanation of the problem. Most citizens are probably reasonably fair-minded and would be quite appalled if they knew the extent of systemic racism and how it actually works. But unless they're the targets or the victims of that systemic racism, they may not see it. When you go off to hospital to get your broken arm treated, you're not necessarily aware that the First Nations person in the room next door is not necessarily getting the same quality of treatment. But in some cases, it's quite overt. I remember in Dubbo Base Hospital out in country New South Wales, about 6 hours west of Sydney, where there's big Aboriginal policy. I was in the hospital there with my wife as we were waiting for our son to be born, and I was reading a book called Black Politics. And one of the nurses saw this book and saw it as an invitation to launch into a racist tirade about some of the Indigenous patients that she worked with in the hospital. And that made me aware of an extraordinary level of systemic racism that I wasn't the recipient of, but she was telling me very explicitly, I don't care for Black patients as well as I care for white patients. So that's a story that I often tell in my teaching. If I'm teaching, this sort of topic to nursing students, for example. And most of them, to be fair, are quite appalled when they hear that story. But if they hear perhaps, there's systemic racism in the hospital system without an explicit example, then perhaps they're not necessarily going to accept it or understand it. So I think bringing to the fore explicit examples and explaining how they actually affect real people's lives and real people's quality of care is something that's morally powerful and hopefully politically useful.
Yeah, those are very, very pertinent points. I think as like future healthcare providers, we're going to be able to, like you said, give explicit examples, and it can maybe help change the stigma and like how government is back, and maybe shed a light on how there is systemic. Yeah, it's a very, very good point. Yeah, thank you so much. Are there other questions?
I actually had a pretty quick question.
Yeah.
If it's fine, yeah, okay. So first of all, thanks so much for this presentation. I learned a lot, and you drew very, very pertinent comparisons between the situation in the different countries. And I was actually interested in reading a bit more about like the philosopher Norman Daniels, about the moral philosophy of healthcare system. So do you have any specific text or book that you would recommend us reading?
I think I sent Clara a copy of one of my books, and in the references to that is a reference to Daniels, to what I was quoting just now. I can't remember the title at the moment, but it is there in the references of the book that I've sent to Clara. So and there are a few other references on the moral philosophy of health and healthcare. The sociologist Sir Michael Marmot is also very interesting. His work on the idea of what he calls a social gradient of health. So how things like, wealth is a determinant of good health, and but wealth is not evenly distributed, and so on. That's also a really good read, and there's references in my book to that.
So for your reference, I added all of the references you sent me. I sent it to you in the chat, so if everyone's interested, they're in the chat.
Okay, I found this on the web for you. Is the reference to Daniels to what I was closing on just now. I can't remember the title.
Sorry, Siri was trying to help me answer the question, and then sort of got it partly right, but not fully right. So yeah, the reference to Daniels in my book is the same reference I quoted from this afternoon. So yeah, it's a very interesting and instructive read that I guess will help you think really deeply and critically about the moral context of your work as a clinician.
Just to make sure, which book are you referring to? Since I see like 4 different things.
Oh, okay. All right, sorry, you do. Hey, and
They all look interesting.
they are, but they're not the one that you wanted. My apologies. I will send Clara a copy of the book I was referring to. And
Okay, perfect.
And I'll note the Daniel's reference for you.
Perfect. Thanks so much.
Yeah. Oh, and Michaela's got her hand raised. Hi, Michaela.
Hi, I'm sorry. Good day. Good day
Hello.
to you.
Yes, it's early morning here, 5:05 in the morning.
I'm from AMSA Philippines. I'm from the Asian Medical Students Association Philippines,
Yep.
and it's 2 a.m. here.
Oh, okay.
Yeah, I'm one of the representatives of our local membership or national membership organization. Anyway, it's kind of as I was listening to your talk, to your discussion, I can't help but feel very disheartened with the current government we have. I don't know um if it's if the other countries are aware with the current situation that we have in the Philippines, but in a nutshell, we have one of the worst pandemic responses in the whole world. And I
Yeah.
think so I think that's out there already. In terms of prioritizing indigenous peoples, well, for starters, everyone here is not being prioritized by anything. But it's I really just want my experience here to be sustainable. I mean, it will be, but if I were to ask, what will be the one takeaway or one advice that you can give me as a medical student that I can really apply, probably, at this moment, that can help address the gap that that we have in common, the gap that indigenous peoples don't, the minorities don't receive in terms of healthcare.
Well,
I
I think the political situation in the Philippines generally adds enormous layers of complexities. You know, the one really significant advantage that I think Indigenous peoples in Australia, Canada, and New Zealand have is that their political systems are stable. And it's possible to study how they work, learn how they work, and explore avenues for influence. I suspect that's an extraordinarily difficult, if not impossible, task in the Philippines, not just for Indigenous people, but for anybody. So, yeah, I think that question would be much easier to answer if, well, certainly if the current regime in the Philippines is thrown out. I understand there's an election coming up soon, isn't there?
Yeah, in May 2022.
Is the president standing again?
No, but I think his daughter is running for position.
Yeah.
As a president.
Well, I guess when you've got people like that manipulating the political process and controlling it for ends that aren't necessarily even pretending to be concerned with public welfare, you need someone smarter than me to help, I think. Yeah, I know, and I know that Indigenous peoples from the Philippines contribute to international forums and discourses and had influence over the drafting of the UN Declaration on the Rights of Indigenous Peoples and so on. But their political claims and arguments are just so much more difficult to make because of the instability of the political system. Obviously, its current leadership adds a further layer of difficulty, but the system itself just works so differently to those in the countries we've been talking about today. So even though in Canada, Australia, and New Zealand, Indigenous peoples are very much on the periphery. They didn't design the systems. They were excluded from helping to design the political systems. Because they're stable, it is possible to make sense of how they work, even if they don't always work in good ways, and try to work within the constraints, because you know what the constraints are. In the Philippines, I suspect the constraints are forever changing, and not always in ways that are obvious. So I know that's a hopeless answer, but that maybe reflects the complexities, and also I'm just not an expert on the Philippines. So good luck, and let's hope the international community can, put some pressure on the regime to, I guess, behave reasonably and competently, and conduct fair elections, and those sorts of things that I guess are preliminary to being able to have the kind of conversation we've just had about these other places.
Thank you for that, Doctor. Really, I agree. I really agree with what you just said. I mean, the very concrete solution that a third world country with this type of government can employ is to really scrap the whole system. And yes, I really agree. And no, I would just like to say that that is a really wonderful answer. Like, even though it did not, even though you think that you did not address what I was asking, it actually gave me an insight, and it gave me a boost to advocate further for a better government, because that's one of the things that I am doing right now. And yeah, it gave me a boost because I didn't know that a lot of people are actually aware with what's happening with our country, and just gave me hope, because it made me realize that our situation is actually so worse that people from other countries,
everybody knows about it.
Yeah.
Yes.
And
well,
thank you
for the question. Yeah. Sophie.
Yes. First, thank you for the presentation. That was really, really interesting. And actually, I was thinking about what you were talking with the inclusion of Maori people in the government. And I was wondering if you had maybe some readings to suggest, or articles about the positive impact on the health of people that come from the inclusion in the government. Or maybe it's too recent for such studies to have been done, but I think it could be interesting to have these data, and that could help maybe, for example, for advocacy in Canada. So I was wondering.
Yeah, I'll send some readings through. There's a couple of reports, I think, that have been done recently that might be useful. So it's 5:15 in the morning, so I might go and have a rest for an hour or two, and then I'll put together a little list of readings, and maybe send them to Clara to share. And if anybody thinks of any questions later on, send me a message or give me a call. But there's been a lot that's been written on these things, and yeah.
Great. Thank you so much.
Yeah, I'll put together a list of 3 or 4 things that might be interesting. I'll just write that down.
So if anyone wants to get the articles, I can send them to you by email. So if you want, you can send me your email in the chat, and I'll note it, and I'll send you the articles.
Okay, so those, just have a look at what's in the chat there. Yeah, that second one, we are all here to stay. That's actually available for no cost from the publisher's website, and you can download it as a PDF. So you can just open it up and type in health, and it'll take you to the sections that deal with health if you're interested there in what the declaration means. I don't talk about health and that in great detail, but there's some sort of peripheral things that just might be helpful. Same with the others, they're not specifically about health, but I do have a book, Indigenous Health, Power, Politics and Citizenship, and I've got free electronic copies of that which I can share. And then, so I'll send that through, and then a couple that answer your question, Sophie. Anything else anyone wants to talk about? Well, thank you again for the invitation to speak. It's always good to have opportunities to talk about one's work to different audiences, and would have preferred to have come to Montreal and spoken in real life, but